Hello everyone, my name is Karishma and I'm joined by Bikesh, Fatima, Lisa, and Kavita. Today we'll be presenting our case study on Mr. Adrian Shani, a 41-year-old patient who experienced rapid clinical deterioration following multiple yellow jacket bee stings. A MET call was initiated in response to his worsening condition. We will now go through the high priority clinical findings. Airway. Mr. Shani's airway is currently patent. However, there is mild swelling of the tongue and visible swelling to the right side of his face. These signs are concerning for potential airway compromise, particularly in the context of his recent exposure to multiple bee stings. Breathing. He is in significant respiratory distress with a respiratory rate of 30 breaths per minute and an SpO2 of 86% on room air, which improved to 96% on a non-rebreather mask at 15 liters per minute. He is only able to speak in short sentences, and on auscultation there are diffuse crackles, wheezing, and stridor, suggesting both upper and lower airway involvement. Circulation. He is hypertensive with a blood pressure of 87/48 and tachycardic at 132 beats per minute. His capillary refill time is delayed at over 4 seconds and he has cool, clammy skin. Both his radial and pedal pulses are weak and there is a noticeable edema in the upper limbs. Disability. Mr. Shani is drowsy with a GCS of 14 and is disoriented to time, place, and person, indicating early neurological decline. Fluid. He is alguric, indicating reduced urine output. He is currently receiving IV saline at 80 milliliters per hour and is unable to tolerate oral fluids. Now I'll hand over to Kavita.
Thank you, Karishma. I will now discuss the pathophysiology that Mr. Shani is presenting with. As we know that Mr. Shani has a medical history of bronchial asthma, hay fever, and as of recent, type 2 diabetes mellitus. These pre-existing factors are significant contributors to his deterioration. Let's take a look at how and why. Type 2 diabetes puts Mr. Shani at higher risk of delayed recovery, as evident by his high BGL, which would then result in the increased release of cortisol and catecholamines from overloaded functioning, therefore leaving him in an immunocompromised state. We'll take a look at the delayed anaphylactic shock. The yellow jacket bee stings have led to IgE-mediated hypersensitivities, whereby the degranulation of mast cells and basophils have created an excess release of histamine, cytokine, platelet activating factors, and leukotrienes. Due to this response, systemic vasodilation and capillary leak have resulted in edema and hypertension. This response is also responsible for the facial swelling, hypotension, urticaria, and angioedema and bronchospasm. Next, we will assess Mr. Shani's respiratory impact. The process of degranulation incites hyperresponsiveness and mucosal creation. Mr. Shani's existing bronchial asthma has exacerbated, presenting as the increased respiratory effort, leading to compromised airways and the evident tachypnea and hypoxia on room air, but being observed in his PaO2. This process indicates Mr. Shani is experiencing metabolic acidosis, as can be seen from the ABG markers of his pH being 7.25, his HCO3 is 21, and his lactates are 4.9 millimoles per liter, indicative of tissue hypoxia and anaerobic metabolism. We can observe the compensatory mechanism of tachycardia to counter the hypotension, although this reduction in volume has now resulted in hypoperfusion of the renal and hepatic functions. Mr. Shani's delayed capillary refill time, cool peripheries, and oliguria is triggered by the lactic acidosis cascade into his altered GCS14 and systemic organ dysfunction. Speaking of his reduced GCS, it can be alluded to cerebral hypoperfusion and systemic toxicity, which has impacted the CNS. His further labs of creatinine, BUN, and GFR are all indicative of AKI, also triggered by his hypotension and hypovolemia. Much like his kidneys, it can be concluded that Mr. Shani has hepatocellular injury. Due to the systemic immune dysregulation and delayed intervention of his anaphylactic shock, his markedly increased white cell count, C-reactive protein, and lactate determine the instigation of systemic inflammatory response syndrome, then leading to MODS. I will now hand over to Fatima to discuss the diagnostics.
Thank you, Kavita. I'll be discussing two key diagnostic results from Adrian Shani's case and how they reflect the underlying pathophysiology of his anaphylactic shock leading to MODS. First, let's look at Adrian's ABG. After being stung by multiple yellow jacket bees, Adrian developed a delayed anaphylactic reaction. This triggered the release of inflammatory mediators like histamine, leukotrienes, and prostaglandins, which cause vasodilation, reducing vascular resistance, increased permeability, leaking fluid into the interstitial space, and smooth muscle contraction, causing bronchospasm. This led to narrowed airways and poor gas exchange, shown by his PaO2 of 51, clear evidence of severe hypoxemia. His stridor, tongue swelling, crackles, and wheezing also point to airway inflammation and lung congestion. Because his tissues weren't getting enough oxygen, they shifted to anaerobic metabolism, leading to a raised lactate of 4.9 and metabolic acidosis, which is reflected by a pH of 7.25 and a base excess of negative 8.3. In summary, Adrian's ABG results show signs of hypoxemia, respiratory distress, and poor perfusion related with anaphylactic shock and early MODS. Next, let's look at Adrian's renal results. Here we're seeing clear signs of acute kidney injury, which link back to the same pathophysiological process. When Adrian experienced anaphylactic shock, volume depletion occurred, meaning less blood flow was flowing to vital organs such as the kidneys, which are highly sensitive to changes in perfusion. As the kidneys became hypoxic, the renal tubular cells began to suffer damage. This likely led to acute tubular necrosis, which reduced his glomerular filtration to 16 mL per minute, causing toxic waste to accumulate and explaining the high creatinine of 3.0 and BUN of 65. The protein, blood, and glucose in his urine supports glomerular and tubular injury, and his oliguria and concentrated urine shows the kidneys are struggling to regulate fluid and waste. This result supports that Adrian is in renal failure as part of MODS driven by hypertension, inflammation, and cellular injury. MODS is a systemic inflammatory response, not just organ failure. In Adrian's case, the immune system triggered widespread cytokine release, causing early damage to his lungs and kidneys. If not managed, this can extend to the liver, heart, and brain. His confusion, low GCS, hypertension, and reduced urine output reflect this progression. Together, Adrian's ABG and renal results convey early multi-organ dysfunction. Timely management is important in preventing further deterioration and irreversible organ failure. Thank you, and now I will hand it over to Lisa.
Thank you, Fatima. I am Lisa, and today I'll be talking about the main pharmacological treatment for anaphylaxis, epinephrine. Epinephrine is considered the most effective treatment for anaphylaxis and is always the first line of therapy in emergencies. According to Resuscitation Council UK 2021, giving epinephrine formerly via intramuscular injection can be life-saving. Epinephrine works by reversing low blood pressure, restoring circulation, to vital organs and preventing respiratory failure. It relaxes the airway muscles and reduces muscle swelling, helping to open the airway and improve breathing. For example, in Mr. Adrian's case, where his blood pressure was dangerously low at 87/48, epinephrine should be given immediately through an intramuscular injection. This helps to stabilize his blood pressure, boost oxygen saturation, and reduce the risk of cardiac arrest. It's important to emphasize that delaying epinephrine administration is linked to worsened outcomes in anaphylaxis. It shouldn't be replaced or delayed by any other medication. The best place to inject epinephrine is in the mid-outer thigh, as this allows for fastest absorption and best results. I will now hand over to Bakash, who will explain the role of antihistamine.
Thank you, Lisa. I will now discuss the function of antihistamines in the management of anaphylaxis and allergic responses. While antihistamines are frequently employed to alleviate allergy symptoms, they are not advised as the primary treatment for anaphylaxis in a hospitable environment. The Resuscitation Council UK underscores that epinephrine should always be delivered as the initial treatment. Antihistamines can serve as an adjunct therapy, particularly following the administration of epinephrine. They assist in alleviating chronic symptoms such as urticaria, pruritus, or hives, which may continue following the management of the actual phase. For urticaria, second-generation H1 receptor antagonists such as cretosine, loratadine, or fexofenadine are favored because to their less sedative effect and superior safety profile. Furthermore, antihistamines do not address airway edema, shock, or bronchospasm, critical life-threatening aspects of anaphylaxis. Hence, they can never replace epinephrine. In summary, epinephrine is vital for saving lives during anaphylaxis, while antihistamines facilitate recovery after the patient is stabilized. To summarize the presentation, Mr. Adrian Sai case illustrates the rapid progressions of anaphylaxis to multi-organ dysfunction if not addressed swiftly. We examined the impact on his airway, respiratory, circulatory, neurological, and renal systems, as well as how these arterial blood gas and kidney results indicate this decline. We also addressed the significance of prompt epinephrine administration and the auxiliary function of antihistamines in alleviating allergy symptoms post-stabilization. This example underscores the imperative of identifying clinical warning signals and responding promptly to avoid additional consequences. On behalf of myself, Kavita, Karisma, Fatima, and Lisa, I extend our gratitude for your care. Thank you for listening and your time. Thank you.